Okay, so without delay, can we start, please? I will, if you allow me, I would like to welcome all dear colleagues here today, Dr. Majdi, Dr. Vishali, and Dr. Ramzi. Hello, Dr. Ramzi. Again, I
Hello,
can see
hello.
you after a long period of
Thank
time.
you.
Also, Vishali, Dr.
Good to see
Abdullah
you.
Labban also. I hope that Dr. Fahad, he will, and Dr. Majdi will join soon, inshallah. So we can go, please, to introductions. The first speaker. Management, can you please show, share with me? So the first speaker is Professor Vishali Gupta, a Retinal and UV expert, Professor Department of Ophthalmology, Advanced Eye Center, Postgraduate Institute of Medical Education and Research, Chandigarh, India. And she is going to give a talk about imaging biomarkers in diabetic macular edema. Dr. Vishali, please.
Thank you. Thank you very much, Professor Amrit. It's always a pleasure to be invited by you and to participate in the amazing meetings that you do. Thank you once again. The topic,
Pleasure, Doctora. It's our pleasure. Thanks a lot for you.
it's like home to me. So the topic that I have been given are the imaging biomarkers in diabetic macular edema. So as we understand, the diabetic macular edema is caused because all the cell types and virtually all the layers, including the choroid, glial, and other tissues, are affected, thus producing what we see topographically as macular edema. The question that we all have been trying to answer is it way that there are some imaging biomarkers that can tell us about the prognosis and eventually result in the personalized treatment as to which medication needs to be given. So the first question is it easy to pick up these imaging biomarkers in the clinic practice? The second is, can they influence the treatment plan? And third is, do they indicate prognosis? So let's look at some of the very commonly observed biomarkers that we do. And I have removed CVI for lack of time, but I would be discussing the others one by one. This is no-brainer that if you see epiretinal membrane on top of a macular edema, it is a tractional variety. And if due to whatever reason you want to try injections, they by and large will not work. For example, this patient had received injections from outside, but all you needed was just a vitrectomy, and you can see the macular edema going after vitrectomy. The second biomarker is DRIL, which is disorganization of the inner retinal layer. Now, this is actually a predictor of visual acuity in eyes that have center involving diabetic macular edema. And early change in the DRIL, this identifies eyes that are likely to have subsequent visual improvement or decline. And you can actually compare the DRIL with OCTA, and OCTA indicates loss of blood flow and retinal ischemia corresponding to DRIL. So it's a very robust marker. And this is how it will look. You look at the fundus picture, it looks like any other diabetic macular edema, and you really do not know that this patient would have poorer prognosis unless you look here on the OCT and you look at the disorganization of the inner layer, which is a sign that this layer, once it is involved, it's going to be associated with some abnormalities in the outer layer and a poorer visual prognosis. This is just a closer up view of how DRIL would look like. But DRIL is a bad news in terms of visual acuity. The third one, a parameter which we all, should look at is outer retinal disruption. Now, this is the fundus photograph of a 50-year-old male who has received laser and PRPs and multiple intravitreal injections, and his vision is not improving. Now, when you look at his OCT, there is a large, probably a long staying cystoid space, and look at the integrity of the photoreceptors. So once this photoreceptor integrity of the outer layer is gone, due to hypoxia long-standing, but this again is a biomarker for poorer prognosis. The fourth one, which are very, very popular, are hyperreflective dots. Now, these are the hyperreflective dots, which have very specific characteristics, and they are believed to be aggregates of activated microglial cells. They're present both in the inner retina and outer retina, and if you see too many, it means this is the edema, which has more of an inflammatory component actually, because the cell death component is more. HRF may decrease after anti-VEGF injection. And this is just an example of a patient who had some of these HRF, not too many though, which responded to anti-VEGF injection. However, if you have so many of them, like this patient, too many HRFs and subfoveal serous detachment, these are the kind of the patients where inflammatory cascade may be playing more important role than the VEGF. So if you're seeing a clinical biomarker that this patient is more likely to respond to intravitreal steroids than anti-VEGF. Now I would show you this patient after intravitreal ranibizumab. There is some response, but still you see a lot of these hyperreflective dots, and the patient finally receives intravitreal dexamethasone implant because literature has addressed this issue and responds to that. The fifth biomarker is the presence of subfoveal neuroretinal detachment. As you can see, many of our patients do have this. It is again a sign of an underlying inflammatory pathology because microglial cells attract, there could be just impaired choroidal blood flow. This kind of detachment might be seen in 15 to 30% of patients with diabetic macular edema. It is especially very common once you have performed cataract surgery because it's induced by inflammation. So if you have a pseudophakic patient that is resulting in macular edema with serous detachment, again, this is the biomarker where I would prefer to give steroid rather than anti-VEGF injection, because as you can see, pre-injection, post-injection anti-VEGF, not much response, but it's likely to respond to steroids. The last marker is fundus autofluorescence. Fundus autofluorescence signals are thought to be derived from lipofuscin, which is present in the RPE cells in degenerative, acquired, as well as inherited diseases. Now, during diabetic macular edema, IFAF caused by accumulation of oxidative products induced by activated microglial cells. So what I'm going to show you is that this is diabetic macular edema. We look at it, both the eyes, they look similar to me when I look at them clinically. Both of them have been treated. Right eye vision is 20/80 and the left eye is 20/200. So why is it so? Are there any biomarkers? Now, we do OCT, we understand the right eye also has fluid 350. The left eye is bad. As we see, there is a cystoid space, and there is probably compression of the outer segment. And of course, there are hyperreflective dots that we mentioned. But in addition, when we look at the autofluorescence, you see this area in the left eye is increased autofluorescence. Studies have shown if you have increased autofluorescence, that would mean that prognosis and the visual potential in this eye may not be as good. So you may have to be much more aggressive. This is just to show the example. And even after treatment, though we result in the resolution, but the eyes that had increased autofluorescence do not have a very good visual prognosis. So 3 questions we started with, and we are going to end with answers to those questions. The first, is it easy to pick up these imaging biomarkers in clinical practice? Yes, they are straightforward. We just have to look at them. Do they influence treatment plan? Yes, because the presence of the markers like hyperreflective dot, subfoveal serous detachment may give you a clue that this patient is unlikely to respond to anti-VEGF therapy. And third question was, do they indicate prognosis? Yes. If you see the trail or if you see the outer photoreceptor layer totally knocked out, that indicates that these patients would have poorer prognosis. All of us would still treat the patients because they have macular edema, but it's good idea if we can prognosticate them and talk to the patients so that the patients have real expectations from us. So I think these biomarkers are just a first step towards the kind of the era of personalized or a customized medicine that we are moving. And every day we have now more and more being added to. So I have covered only those which all of us can use. Thank you very much once again.
Thank you very much, Dr. Gupta, for the nice lecture. I'm sorry I was in, but the guy didn't put me in as a panelist. That's why I was watching, but now I'm moderating. And I think Dr. Al-Amri will take a relief now. Thank you so much for this presentation. I liked it very much. It's very, very concise and very informative, because we all know that we have many imaging in diabetic macular edema, but biomarkers is one of the very important things, especially with the development of OCT. We can know the prognosis, the outcome of the patients. Also, we rely on it pre-injection and post-injection. Thank you so much. But my question is, when you see these biomarkers, do you go directly to steroids, or you still use anti-VEGF in these cases?
If I see it in a patient of pseudophakia, I straight away go to intravitreal dexamethasone implant. If I see them in a patient who has been previously treated but come to me for the first time, straight away implant. And if I see very poor visual acuity and these markers are really obvious, you know, they are there, I do give steroids as a first line of therapy.
Thank you. I totally agree with that, because these are chronicity, inflammatory. So they might respond to anti-VEGF, but sometimes they are resistant and it will take longer time to respond. And I think one Ozurdex will do the problem in this, will do the job in this case.
I initially tried to control it with Ozurdex and then may follow with anti-VEGF rather than giving anti-VEGF first and then coming to Ozurdex, because it saves time, you know.
How much on fundus autofluorescence you rely? I mean, I know it shows the prognosis, but do you do fundus autofluorescence for most of your cases, or just few? I mean, certain cases you prefer to use fundus autofluorescence?
I just added it for my talk. I was reading and then I looked at my patient and I said, wow, this is showing increased fluorescence.
Yes.
Interesting, I just do OCT and OCT angio sometimes now.
That's all.
I do it for my patients to see disease activity, but not my diabetics now.
Okay, thank you. That's what I expected. It's not in that clinical practice in diabetes, because we don't want to overburden them with more investigation. But as you said, you do it sometimes when you suspect that there is a non-improving in the vision and the macula is dry, to see if it's extensive atrophy. And one more thing, I do it in cases who did previous laser, like they used to do grid laser or focal laser, to see where is the laser sites, if I'm going to, you know, to augment this laser or to do further laser, to know where is the old scars, so I will not work on it on again. But that's it. Thank you so much for this. Let us move to, thank you so much. Let us move to the next presentation, my dear friend, Dr. Ramzi Afshi. Dr. Ramzi is a professor of ophthalmology and chairman and founder of Retina Eye Hospital, Bursa, Turkey. He's a dear friend. He's a good surgeon, very excellent surgeon. And I'm glad that he with us today in the medical retina webinar, and I'm looking forward to his talk. Please, Dr. Ramzi, nice to see you.
Hello, thank you, Dr. Magdi, my dear friend. So it's a pleasure for me to be here in this meeting again, and I would like to thank Dr. Mohammed Al-Amri for this invitation. And today I will speak about the current management treatment of diabetic retinopathy. What's the gold standard treatment, laser or anti-VEGF? These are my financial disclosure. And as we all know, retinal photoregulation, laser photoregulation has been a gold standard treatment for diabetic retinopathy for over 45 years. And all we have numerous cases that remains stable after completing PRP for many years, and they also reduce the number of visits to up to once a year. However, peripheral visual field loss has become controversial after anti-VEGF treatment. So again, as we know, anti-VEGF treatment is not only stop the progression of diabetic retinopathy, but also regress or even improve it. And there are two studies that we all know which compare the results of anti-VEGF treatment and PRP in diabetic retinopathy, and Protocol S and Clarity studies. As you know, Protocol S compared the results of ranibizumab versus PRP, and they published a 5-year result in almost 3 years ago. And at the first 2 years, ranibizumab group was significantly better visual at letter score comparing the PRP group. However, at the end of 5 years, this was not significant, and the results was same. And the number of injection in ranibizumab group was 19 injection, while 5.4 injection in PRP group. And in PRP group, anti-VEGF was administered only in case with concomitant diabetic macular edema. And what about the adverse events in 5 years? There was not significant difference between two groups, even in terms of vitreous hemorrhage and vitrectomy. However, diabetic retinopathy severity at 5 years was in favor of ranibizumab group, and regression of PDR to non-PDR was observed in 33% of patients, and in 10% of patients there was no diabetic retinopathy, and two-step regression diabetic retinopathy severity was observed in almost half of the patient. So what about the peripheral visual field loss? Again, at the first 2 years, it was significantly better in the anti-VEGF group, but at the end of 5 years, this difference was not significant. And the Clarity study compared the aflibercept versus a PRP in diabetic retinopathy, and all the parameters in this study was in favor of aflibercept. However, there is some weak point of this study, and they published 2 year results, and 50% of this case received treatment prior to the study, and 77% of this case have low risk of PDR, which is level 61 or 65. And the most important thing, the long-term results are not available yet. So VEGF is the main triggering neovascularization in VDR, and when we remove VEGF from the vitreous cavity, we observe improvement. And this happened in the laser PRP, is slow reduction we observe in VEGF, and anti-VEGF cases we observe fast reduction of VEGF from the vitreous cavities. What about the patient who dropped out prematurely from study and did not continue treatment? The rate of this patient is not low at all, and in Protocol S study, almost 40% of patients lost to follow-up during this trial. And what happened to this patient, we don't know, because there is no results from Protocol S. I think this is the weak side of the Protocol S study. However, Obeid et al. Reported their results of patients who drop out from the study, and the duration of without follow-up about is 1 year in this study, and they observe serious complications that treat vision in patients who receive only anti-VEGF treatment comparing to PRP group, and such as 40% of patients they observe neovascularization. This neovascularization in 13% is rubiosis, and almost 1/3 of patients they observe tractional retinal detachment. Again, the cost analysis, when the cost analysis, both aflibercept and ranibizumab treatment is significantly much more expensive compared to PRP treatment. So in summary, the advantage of PRP is provide lifelong efficiency in PDR and fewer follow requirement compared to anti-VEGF, a lower cost compared to anti-VEGF, no risk of endophthalmitis and systemic side effects, and more stable result in a patient who lost to follow-up. The disadvantage is peripheral visual loss, but this also become controversial after the 5-year results of Protocol S study. And what about the anti-VEGF? And the advantage of this treatment is lower risk of diabetic macular edema. It's occasionally need PRP, and they provide regulation of diabetic retinopathy severity. However, this is far higher cost, and they have a risk of endophthalmitis. This is not so important, but the important one is serious complication in patient lost to follow-up. This is extremely important for the treatment selection for us, because in real life, the rate of patient who lost to follow-up is much higher comparing the trial studies. And even in this protocol S study, the rate of the patient who lost to follow-up is about 40%. I think in real life is more than 70, maybe 60, or maybe 70% of patient lost to follow-up. And therefore, we should take care about this patient, that what happened later on. So the question is, does PRP still remain the first-line treatment for patients with newly diagnosed PDR? Regarding the high cost of anti-VEGF and loss to follow-up rates, PRP remains the gold standard treatment of choice, except cases for complicated with DME, vitreous hemorrhage, and neovascular glaucoma. We prefer anti-VEGF and can be beneficial in those cases. What about the other question is, what are the key points while performing PRP? We should avoid insufficient treatment. And we observe insufficient treatment, neovascularization, and vitreous hemorrhage, and over-treatment may cause visual field loss. Insufficient treatment is far more dangerous than over-treatment, and the most important cause of vitreous vitrectomy necessity is insufficient treatment. Therefore, we should do optimum PRP in this patient. Is it appropriate to perform selective laser rather than PRP, such as angiography assisted laser for ischemic area only? So this is controversial, but there's no strong evidence. VEGF production continues in other areas, and therefore conventional PRP should remain the treatment of choice in this patient. And we can also see hemorrhage in adequate PRP and stable retina after many years. And how should we approach in this case? Should we do additional laser? I think it's not always a sign of activation, and hemorrhage can also occur when there's a traction on the vitreoretinal interface, and we can check the vitreoretinal interface with the structural OCT. And if there is traction, we should prefer vitrectomy instead of laser treatment in this patient. So in conclusion, VEGF is a key mediator of pathologic angiogenesis, and anti-VEGF is at least as effective as PRP in short term, and we may prefer the anti-VEGF treatment in patients with DME, and also in combination with PRP to reduce number of injection. However, PRP still remain the gold standard treatment for PDR, at least in my practice. And the cost and frequency of visit and patient compatibility should be taken into consideration while deciding the treatment. Thank you for your attention.
Thank you, Ramzi, for this very nice presentation, and you really summarized all the points in our head. But let me ask you, you said it's still PRP is the gold standard in practice, and I think it's in all of our practice, once we see the patient with proliferative diabetic retinopathy, PRP is still the gold standard. As you said, if we do PRP properly, I think the patient will be safe for a long, long time unless he's uncontrolled. But let me ask you first, if you have a patient with a proliferative diabetic retinopathy and diabetic macular edema, of course you start with injection, but would you keep injecting till the macula is completely dry and then do PRP, or you do injection and then half PRP and then continue the PRP? What's your practice?
This is a good question, Magdi. As you noticed that always start with the anti-VEGF injection this patient, but see the patient a year, 1 month later, if still there's a huge amount of macular edema, I continue to second injection. There's a significant irrigation, but not completely dry. I can start PRP and do injection again, PRP step by step. But if the first one injection is not really really regress the thickness of the macular edema, I do second injection before starting PRP in this patient.
That's a
sometimes good, third injection.
Yeah, yes, that's a very good way, because we should not wait for 3 or 4 months until the macula is completely dry. Otherwise, we should start PRP very early, even after the first or second injection, so we can do it hand in hand. When the macular edema is gone, the PRP start to work, because we all know that laser photocoagulation does not work immediately, and it takes 4 to 6 weeks at least to to stop the VEGF release. That's one. The second thing, as you showed us in the protocol, is all these patients escape. You said in the real life practice, they are more. I think they are much more, as you said, because it's a burden to come every now and then to get an injection. Not only the burden of the money, because some of the patients are insured, but the burden of coming in and out. So most of them are lost. But when you do PRP, very good PRP, and you forget about the patient, because this patient might come in 3-4 years. He said, I'm still fine, but I'm coming in the follow-up. So it's a very good warning. Again, PRP is still the gold standard, but you do it properly. As you said, you don't overdo it, you don't underdo it. But it's the best thing is to do PRP so you can sleep tightly and know that this patient will not come with a severe complication like vitreous hemorrhage or these things, especially if they escape the shot. Because I think these shots, like, sedative, it keeps them dry, it keeps them seeing, but once they lose the time of coming back, they get aggressive. Neovascularization, it happens with me once. I have a patient who did fluorescein angiography after the injection, and I wrote in the report, he's not proliferative, there's no proliferation anymore. But 2 months later, he came with massive vitreous hemorrhage. So again, it's a warning that this patient might still quiet for 3, 4, or 5 months. And once they are recurrent, they are very aggressive. Thank you so much, Dr. Ramsey, for this. And I ask other panelists, Dr. Fahd or other panelists, to have any questions to Dr. Ramsey for this nice lecture. Please go ahead.
Yeah, thank you, Dr. Magdi, and thank you very much, Dr. Ramsey, for this nice presentation. And I totally agree. Yeah, PRB is the gold standard. And recently, actually, over the past years, we are experiencing a big problem from patient dropout, especially those with type 1 diabetes. They are usually, when they reach this stage, and receiving injection, and then for one or more reason due to other ongoing health problems, the time they start dialysis or they have peripheral neuropathy, leg problems, they skip out from the treatment protocol and suddenly they come to us with very aggressive proliferation and sometimes very advanced stage. And I totally agree with you that whenever possible, BRB and always over treatment is better than insufficient treatment when possible.
Thank you. Thank you, Dr. Abdallah. Dr. Fahd, would you have any questions, or you can introduce the next speaker if you allow me?
Yes, so no, thank you, Magdi. The next speaker is Dr. Narayan, who's a consultant ophthalmologist in Prasad Eye Institute in India, and he'll be talking about the landscape of anti-VEGF biosimilar molecules. So this is a very kind of interesting and fascinating talk. So here in Europe, we're expecting biosimilars definitely next year, but I think India has a head start. So we're looking forward to hearing this talk. Thank you ever so much.
Thank you so much for the kind introduction. I'll be sharing my presentation now. Please let me know if you can see my presentation.
Can see it clearly, yes.
Okay. So once again, very good evening to you all, and I thank you for the kind invitation for my talk on the landscape of biosimilars. I do not have any financial disclosures. Biologics are a wide range of products such as vaccines, blood, and antibody molecules, which we are all aware of. And the reference biologic is what we also know as the innovator molecule. So what are biosimilars? Biosimilars are highly similar to the original reference product, or what we call as the innovator molecule, with no clinically meaningful difference. But we must remember that they are similar, but they cannot be the exact same molecule. This is where the difference comes with a generic product, let's say of an oral medication, of an eye drop. They have to be exactly the same. But in biosimilars, they are similar, but they may not be exactly the same. So here, for example, on the left-hand side, I've mentioned the small molecules, where you have the generics. But when you come to the complex biologics like monoclonal antibodies, this is where we call them as biosimilars, that they are very similar, especially in clinical efficacy and safety, but it is almost impossible to get an exact molecule. So, but why are we talking about biosimilars versus biologics? The main reason is the cost. The cost of producing biologics is very, very high. And as you can see here on this slide, the general cost of production of biosimilars, right from the R&D to manufacturing, it's about 25 to 30% less than the cost of biologics. So overall, it's basically less expensive for the patient, it's less expensive for the healthcare system, and less expensive for the country as a whole, leading to some savings. There are numerous drugs which are protected by patents. This is just a laundry list of different drugs, just to show so many drugs which are going to lose their patent because of the simple fact of time duration. These are all biologics. But the Indian market, there are slightly different patent laws, but also India has taken a lead in the number of biologics which have been now produced as biosimilars. So in India has been one of the early adapters of biosimilars, and the Indian biosimilar market, this is one page, but it doesn't stop here in one page. There are many tables running into different biosimilars. I believe just for bevacizumab, there are more than 10 biosimilars available in India. For ranibizumab, there are almost 4 biosimilars available right now, with more coming in the pipeline. And as I said, the main reason is economic, that uh, uh, pharma companies want to look at biosimilars, something similar to generics. The main pivotal trial for the first ranibizumab biosimilar, which is called Razumab, it was the Re-enact study, and in their phase 3 trial, clinical trial on wet ARMD, they found that Razumab, which is the biosimilar, had improvement of vision of 8 letters compared to week 12, which was 8.6 for the Lucentis, which is the original innovator molecule. And similarly, the reduction in thickness was slightly less for the biosimilar and slightly more for the innovator molecule. This was 104 patients. So many people would have questions on the sample size. What is the appropriate sample size? Why is it less and directly phase 3? But that's the advantage of biosimilar. There have been other trials with Razumab molecule, some prospective, some retrospective, but overall it was proven to be safe and efficacious, including in the Re-enact 2, where it was found to be very similar to the innovator molecule. And this is what the marketing approval in India, which was given in February of 2015. So almost 7 years actually since the first biosimilar was introduced in India. So when it was approved in 2015, there were initially some issues of safety of sterile inflammation in some batches, and they had to rework on them, the company. And this was the landscape in 2017. The Indian Retina Society, when we did a survey of people using anti-Vegf, please look at the top right box. What was the percentage of biosimilars that they were using for all indications? Less than 5%, or about 5%, uh, doctors were using biosimilar in 2017. But now in 2020, when we did the survey, only 11%, you see this yellow one, only 11% have not used biosimilar. Almost 90% of doctors have used biosimilars. So you can see how it has picked up in India. And we also had a question, what is your choice of anti-VEGF in DME? The first choice, 20% actually mentioned that it was biosimilar. Only 47%, this in India, Lucentis is called Eccentrix. Then we have Eylea, but 20% their first choice was biosimilar, and in fact, it has increased now even more, the percentage share. And you can see the sales data. This was 2017-19. It is very low, ups and downs, 800 units per month. But last year, they sold more than 7,000 units per month in last year. And now we have other companies also. These are the names of the companies which have now ranibizumab biosimilars either launched or ready to be launched. So in conclusion, ranibizumab biosimilar market is well established in India, and even the Indian companies are doing EMA trials. The ranibizumab biosimilars have taken the market share of Avastin. So ranibizumab is not competing with ranibizumab alone, the innovator Lucentis, but it is also competing with Avastin, so that you don't have to do all the aliquoting and other issues with that. And initial safety concerns seem to have been resolved. And there is always a debate whether regulatory process should include more number of patients, more longer follow-up. That is something which the BRSA members thought would be more appropriate. I thank you for your kind attention.
Thank you, Dr. Raja, for this nice presentation. Let me ask you one question. Does this biosimilar is as cheap as Avastin? I mean, the ranibizumab biosimilar, is it as cheap as Avastin or cheaper than that?
So it is not cheaper than Avastin. Now, in all of them, you have the drug cost and the injection procedure cost.
Yes.
So the drug cost is much more than a single injection of Avastin. So it's priced slightly lower than the innovator molecule, the drug cost. So, but they give deep discount. There's a price war. So while the list price is slightly less, these companies give a deep discount that it's almost half the price of Lucentis, Accentis, the innovator brand. So that's what the drug price is.
And one more question. Do you consult the patient about the drug? I mean, you tell them that we have this and we have that? Because I know in India, like in Egypt, you don't have not everybody is covered by insurance, but would you consult the patient? Would he prefer this or that? Or you just tell him that this is a cheaper and has the same effect as the original drug?
That's a great question. In fact, every country will have to go through this process initially. Initially in India also, all patients had to be informed about that. But now with 7 years of experience, there is more confidence, and it's more about the molecule. The patients are also comfortable. In fact, they have been receiving, these are multiple injection patients. So each time you don't have to consent them. And also they are now included in the government health schemes. So the national health insurance and state health insurance, all of them cover these biosimilars. So overall, I think it's part of the system now.
Thank you so much for that. Any questions from the participant or Dr. Fahd, the co-moderator? Any questions?
Just a very quick question. Just from your perspective, do you think there's any difference in the efficacy and the safety? Do you think with these biosimilars, are you seeing an increased incidence, say, in intraocular inflammation rates? Or actually, has it been quite a straightforward transitional switch from ranibizumab to a ranibizumab biosimilar?
That's an excellent question, because in the initial stages, as I mentioned, in the first 2 years, there was more sterile inflammation with the biosimilar, which was not picked up in the trial. And that's why a lot of retina specialists have had this opinion that the drug trial should have more patients and longer follow-up, even though for biosimilars it's slightly less. But at this point of time, having had the experience and the companies have modified, they found out what was the cause of the inflammation and they were able to modify it. And I can tell you that inflammation has not been seen just with biosimilar, it has been seen with other innovator molecules also. But once they have refined that, they have been able to bring it down extremely low that nobody talks about inflammation with biosimilars in India at this point of time. So they are pretty safe at this time.
And I don't know if you know, but the ones that they're launching in Europe and the United States, are they a similar biosimilar to what's in India? Or do you think it's a different, it's its own biosimilar of ranibizumab?
So they are different manufacturing companies compared to what we have in India, the European one and the US one. But as I said, biosimilar is just a similar. So if ranibizumab Lucentis is being compared with the Indian biosimilar, there will be some differences, but the Indian biosimilar will be different from the Samsung biosimilar or any other US biosimilar. In terms of clinical safety, they have to show non-inferiority. There is another class of molecules called biobetters. Sometimes you end up that the new molecule or the similar molecule is actually better than the original molecule. They are called biobetters. But overall, I would say what they have to show is non-inferiority.
Understood. Oh, thank you.
Thank you so much. And then let me introduce our next speaker, Dr. Fahd Kuhail. He's a dear friend, a dear colleague, and I see him a lot in the meetings, and I really appreciate his work. He's a consultant ophthalmic surgeon, medical retina and uveitis specialist at Royal Hallamshire Hospital, UK. Please, Dr. Fahd, you are going to speak today about management of hemorrhagic and exudative retinal artery microaneurysm. Please go ahead.
Not at all. Thank you very much indeed. Thank you ever so much. And thank you very much, Professor Magdi Musa, for your kind introduction. So retinal artery arteriolar microaneurysm, or RAM, represents a fusiform dilatation of the arteriolar system with histological evidence of thickening of those arterial walls. RAMs tend to have a predilection to occur in the second or third bifurcation of the temporal retinal artery, and is often associated with systemic hypertension, the female sex, and obviously older age. The Beijing Eye Study estimated the incidence of RAM at around 1 in 9,000 eyes, or 1 in 4,500 adults. And I would say the majority of RAM are asymptomatic and spontaneously resolve, but there is a proportion of RAM who are symptomatic and associated with vision loss, with exudative foveal manifestations such as subretinal or intraretinal fluid, or hard exudates and/or retinal hemorrhages. So I'd like to present a 77-year-old female with a presenting visual acuity of 636 in the right eye, 612 in the left eye. I initially observed her, followed by treating her with focal argon laser directly onto and around the RAM in her left eye. These were her color fundus photographs, and unfortunately, she'd had a pre-existing RAM lesion in her right eye that was chronic, led to exudation and macular atrophy, and foveal RPE hypertrophy at the fovea, so her vision was reduced at 636, whilst the left eye had an infratemporal RAM lesion with some fresh macular edema, and I was keen to do something in that left eye to prevent further vision loss. This was the OCT of the right eye. So as you can see, you've got this area of hyperreflectivity beneath the fovea with some loss of the photoreceptor layer, or the inner segment ad segment junction. So there's some loss of photoreceptors beneath the fovea, and that's because she had an untreated macroaneurysm leading to chronic macular edema that wasn't treated, leading to irreversible vision loss. So I was keen to do something about the infratemporal macroaneurysm in her left eye to try and minimize any vision loss in that left eye. So the plan was to do some laser treatment. And if you compare the infratemporal, if you look at the infrared reflectance, if you look at the infratemporal artery, you can see there's this hyperreflective lesion, which is the macroaneurysm, leading to this infratemporal area of macular swelling. And you can see the laser burns that I've created are kind of these hyperreflective dots just around the RAM. And as you can see, although her edema did improve, unfortunately, I didn't close the RAM, and actually her foveal edema did worsen, and her vision still remained at 612. So I failed to close the RAM with laser treatment. And at that time, this was about 2013, 2014, I didn't have any new strategies. So the only other thing I would have done possibly was maybe do some direct laser to the RAM lesion itself, but there would have been a risk that the RAM would have ruptured, leading to a vitreous hemorrhage, or I could have induced a distal branch retinal arterial occlusion with some visual field loss. So there was going to be risk with additional laser, but as it happened, the patient actually passed away before I could intervene with any additional treatment. But basically, the proposed pathophysiology of Ram is that hypertension, embolism leads to some thickening or loss of elasticity in that arterial wall. And then what you get is a ballooning of that arterial wall, leading to development of a retinal artery macroaneurysm. And then most of the time, it follows the trajectory of the top line, where you get enlargement with eventual thrombosis and spontaneous resolution of the Ram lesion. But occasionally in some patients, that dilatation of that enlargement can bleed, either due to Valsalva maneuver or to anticoagulation, leading to vitreous hemorrhage, or you get some incompetence of the blood-retinal barrier, leading to hard exudation and leakage. And this is where we think anti-VEGF makes a difference because of its vasoconstrictive properties, possibly because it induces thrombosis. It can, or because it stabilizes the blood-retinal barrier, it can lead to macular edema resolution and accelerate the resolution of the Ram lesion. And we think it has a useful role as a novel way of managing the hemorrhagic and exudative complications in a patient who has a Ram and they're getting vision loss. And when I saw this paper or stumbled upon this paper in 2019, it certainly changed my management in patients with symptomatic retinal artery macroaneurysms. And this was a retrospective multi-center paper published in Retina in 2019, where they looked at the outcomes of 32 eyes who had exudative and hemorrhagic maculopathies complicated by a retinal artery macroaneurysm. And all these patients were treated with anti-VEGF. And it seemed that they were treated on a PRN approach. And eyes were treated with an average of 2.7 injections over a mean follow-up of 16 months, with a range between 1 to up to 13 injections over that period of observation. And the main retreatment criteria was subretinal fluid and subretinal hemorrhage. And the best corrected vision improved from a baseline of 6/48 to 6/18, with the CMT statistically decreasing from a baseline by at least 130 microns to upwards to 211 micron decrease at 1 to 2 to 3 months respectively after that first anti-VEGF injection. So there was a functional and anatomical response to serial anti-VEGF injections, but it seemed that it was PRN. But just remember, this is a retrospective study. We didn't have a control arm, so we didn't compare the natural history. So we still can't be absolutely confident that we are making that observation wouldn't be just as good in these patients. But like I said, given my bad experience before, I then, after this paper, adopted this approach in the treatment of my patients, and I'll share 3 cases. This first case is an 81-year-old female with a sudden hysterectomy of a bubble of blood, reducing vision in that left eye. She had a slight improvement over the month, but when she saw me in clinic, her vision was 6/9 in the right eye, count fingers in the left eye, and her vision was limited due to a vitreous hemorrhage. She had a large macular hemorrhage affecting the superior macula with a pale center. So I suspected clinically there was a Ram, but I was unable to see the retinal periphery. This was an optos. I don't have any OCTs to show you because the vitreous hemorrhage was so dense, but clinically I felt that this was a Ram. And she was listed for 3 Avastin injections. And this was her after 3 injections. Her vision had improved to 6/18. And with the eye of faith, if you look along the supratemporal artery as it branches from the disc, there's an area of pigmentary change. That's where the aneurysm was. And if you look at the autofluorescence as well as the RPE change at the macula, this lady had significant subretinal component to a macular hemorrhage, which resolved beautifully with the anti-VEGF, and she has had a remarkable result, avoiding the need for vitrectomy. My second case is a 78-year-old female who again noticed sudden loss of vision in that left eye. Vision is 6.9 on the right, 6.60 on the left. She has if you look, she has marked macular edema and macular hemorrhaging with a supratemporal retinal artery macular aneurysm. And if you look at the OCT through the RAM, she has a change within the RAM, a very there's a marked hyperreflective lesion within the inner retina. She had 3 avastin injections in the left eye. Vision is 6.9 on the right, 6.12 on the left. There's a marked improvement in vision with marked resolution of the RAM, with slight interruption there, but a very good improvement. So in conclusion, consider anti-Vegf injections for RAM close to the fovea, optic disc, papillomacular bundle, and inside the vascular arcade. And anti-Vegfs are a safe and effective approach to managing symptomatic RAM than laser therapy, in my opinion. And I will stop sharing at that point. Thank you ever so much.
Thank you, Dr. Fahd, for this nice presentation. Let me ask you, when you used to do laser photocoagulation, what was your parameters? What was your aim, the rationale of doing laser for macular aneurysm?
Yeah, it's a really good point. Yeah, it's a really good point. So when I used to treat around the macula, I would just use my standard focal laser settings, about 10 milliseconds. And what I would do in the beginning was just get a visible burn and treat around the RAM itself. And then if that didn't work, I would then use a longer duration burn, say 30 to 40 milliseconds, increase the spot size to 100 milliseconds. And then what I was trying to do is to try and induce a change in color in the RAM itself, but I wouldn't go too far because I was worried that I would rupture the RAM. And I just found in my hands, it just wasn't effective and I wasn't making a difference. And patients were progressing like that particular case. So although her macular edema did improve in some respects, she then developed foveal edema. And so it was really just when this paper was released in 2019, I just thought, wow, this is actually what I was looking for. This is what's making the difference. And I don't offer it to everybody. So if they're asymptomatic or it's mild, I don't offer this. But if they have vision impairment or it's hemorrhagic involving the fovea or there's exudation, I tend to give a loading dose of 3. That's in contrast to the paper where you could give it on a PRM basis. But in my hands, I've treated about 7 or 8 now, and I've been really, really pleased with the results, which is why I'm sharing it in today's forum to kind of spread the message that, I think, we may have a new treatment. But just remember, in that particular paper, there was one case that needed 13 injections with no resolution of the exudation. So we may still have to go back to laser if we need to, but now we can now use it as a second line and maybe justify some of the destructive effects because we've now got a safer alternative with anti-Vegf.
I was just going to say that because I have a patient who I injected 3 times, there was no improvement, and I left the patient for the natural course, and after 6 or 8 months, she resolved all the edema. But again, it might work, it might not, and as you said, there's a weak point there. There is no arm, there is no other arm to compare. It's a retrospective study, so it is not for granted. Problem. Yes, everybody's trying anti-Vegf for everything, but in these cases, it is not, it's not on label, it's off label up till now to inject anti-Vegf in macular aneurysm. But it might work, but in a couple of cases I had, it didn't work. In other cases, it works, but it was minimal edema in that case. But as I work with it, I do it PRN once, twice, and if it doesn't work after the second injection, I stop injecting and I leave it to the natural course. Sometimes I used to do laser, but again, the laser didn't do much except if you are using a very heavy burn, closing the aneurysm, and this is not good because you will have a post-arterial occlusion, or sometimes you get rupture if you don't use a larger spot size with a wider burn. So otherwise you might rupture this aneurysm and make things worse. Thank you so much, Dr. Fahd. Any questions from the panelists?
May I ask a question, Magdi? Dr. Fahd, it's excellent talk. So I would like to ask, what do you think about the mechanism of anti-Vegf, how it treats macroaneurysm? And the other question is, what about the follow-up period, the long-term follow-up period? Also prevent the recurrence of macroaneurysm in the same area? Or or it's just effect when we inject, or what's the follow-up time?
What I think anti-VEGF does, I think it stabilizes the blood-retinal barrier. So it must, we think anti-VEGF probably, has an anti-inflammatory or improving blood-retinal permeability, but then I think it has a vasoconstrictive effect. And so possibly the flow through the RAM gets smaller or slower, so it allows it to thrombose and kind of spontaneously kind of resolve. In terms of the follow-up, I give them 3. So I give them every month for 3 months. And then I see them 4 to 8 weeks time. And I've been very impressed by how well it's resolved. And then I see them one more time, say 3 months later. And if there's no recurrent activity, I discharge them, or obviously I give them my number. In the NHS, we don't follow up patients long-term if they're stable. But what I do say, but I'm confident soon I'll come across a patient where I'm going to have difficulty. And I think I did mention in the beginning of my talk, I really thank Magdi for laboring the point. This is retrospective off-label, and we still don't know whether it's better than natural history because we haven't done the study. But I just think because of the bad experience I've had of not treating them, and because there's been good results and I've had anecdotal good results, I am now offering it to my patients, and I'm now hoping to make it the standard of care. But yes, but to answer your question, once you've given the course, see them a month later. If you're happy with the treatment response, see them at 3 months and then discharge. And if you still think there's residual fluid, residual exudate, residual hemorrhage, give them another anti-VEGF shot and keep treating until you think it's completely resolved. But as Magdi said, there's no harm in also pulling back. There's no criticism of you for doing that because there's no evidence base to support that what we're doing is in the patient's best interests. And we've always got to be careful that when we're doing these things and we still don't quite understand how we're benefiting patients, that we do stop sooner, because what we don't want is to harm patients unnecessarily.
Thank you.
Thank you. And we move to the last presentation because we are 5 minutes delayed, but let me introduce Dr. Abdallah Labban. He's a dear friend, dear colleague, one of the nice Egyptian doctors who left Egypt long time ago, went into Japan and then UK. He's going to speak to us about pathomorphology of microstructural changes in diabetic macular edema by OCT and OCTA, and I think it's going to be an interesting case. Please go ahead, Dr. Abdallah.
Oh, thank you very much, Dr. Magdi, for your kind introduction. And it's my great pleasure to be here with you today. I'll try to be concise as much as I can. So can you see my presentation now?
Yes, it's crystal clear.
Fantastic. So I'll try to look at macular edema slightly from a different angle. And as you know that we regularly use OCT for macular edema, we have so many multi-center trials looking at macular edema. Unfortunately, most of these trials looked at 2 main parameters, the central retinal thickness and the visual acuity. But as we all know that many reports show that central retinal thickness has only modest correlation with visual acuity in macular edema. And there should be other mechanisms we can look at. Fortunately, the first speaker, Dr. Gupta, highlighted some of these biomarkers. But actually, there are a few things we can look at in OCT and OCTA. And that's what I call the microstructural changes. And understanding these microstructural changes and their impact as a predictive for visual acuity would be really helpful. And I think this is the first thing before considering any treatment. So we can look at the microaneurysms, how they look in OCT or OCTA, also cystoid spaces, the hyperlective foci, and macular ischemia. Starting with these cystoid spaces, as you all know, this reflects the amount of the leak. They can occur in different layers in the retina. So generally, we can see them at the fovea and the And we look at trying to quantify these cystoid spaces. Those, the one at the fovea or the parafovea, are the most influential on central retinal thickness. Sometimes when these cysts are chronic, we start to see the break into the boundaries between the cyst and start to see them taking a regular shape. And when you see this picture, it's actually a sign that these cysts has been there for some time, and there is an ongoing inflammatory process and leaking process, which may give you some sort of prediction or what to expect when you start the treatment. And the appearance of these cysts will mainly depend on the leaking site, also the leaking pressure, and also the quality of the leaking fluid, which unfortunately we don't have information about that. Interestingly, some of these cystoid spaces, over time, they may get damaged and they break and they develop some sort of intraretinal leakage, and those actually are sometimes resistant to treatment. Some of these cases, sometimes they break through the outer layers of the retina and lead to the development of serous detachment. And this also can modify the response to anti-VEGF treatment. If you think about just only cysts or cysts versus leaking into a subretinal fluid, these tend to be less responsive to treatment. Another thing with the chronicity, that large cysts or chronic cysts, sometimes they are associated with photoreceptor damage, especially if they persist for a long time. And this is something to be appreciated, because when we think of the retina, we need to look at the structure of the retina layer by layer, starting from the outer retina, inner retina, all as a whole pathway or a whole track. And this applies not only for diabetic macular edema, but also for retinal vein occlusion and with age macular degeneration, because sometimes these cysts can be what we call structural cyst. So it's a sign of damage of the retina, and this can give us some insight when we start treating these cases. And interestingly, if you look at all these cases in wet AMD or other pathologies, sometimes these structural cysts are a sign of damage rather than a sign of leak. Moving to the second thing, which is microaneurysms, and this is the main pathological changes in diabetic retinopathy. And using OCT and other modalities, people try to quantify the microaneurysms. They can appear of different size. Interestingly, in OCTs, they look much bigger than other pathological methods like the vascular casting or immune staining. They show very well in OCT angiography, but the detection rate is variable from one machine to another, and also variable if you compare it with the fluorescein. This depends on the technology used for the microaneurysms detection. And this study is really interesting, that looked at the location of the microaneurysms in the OCT, usually located into the inner nuclear layer and outer plexiform layer. Interestingly, which was relatively new to me, that sometimes microaneurysms located in the inner retina, in the nerve fiber layer, or even at the level of the ganglion cell layer. And we're looking at the capsular structure of these microaneurysms, and this will help us to understand the criteria or the patterns of the leak in macular edema. Sometimes these microaneurysms appear as a complete ring, or intact capsular structure. Sometimes maybe like an incomplete ring, and this is the main issue here. When they have an incomplete ring, they tend to leak to the adjacent retina. Interestingly, sometimes they have no ring at all, and sometimes this can be a sign of obliterated microaneurysms. And that would be helpful when we look at scans for diabetic retinopathy or diabetic macular edema, looking at that. So this is a cystoid space, but this is a microaneurysm, and differentiating between both of them will help us to quantify or tailor our treatment plan when we enroll these patients as BRN or treat and extend. Another interesting thing to correlate with diabetic retinopathy are, for example, these are 3 cases. And when you look at the OCT, like the one in the middle, they have very similar changes. You have microaneurysm, cystoid space. But interestingly, when we did further multimodal imaging, these 3 patients have macular telangiectasia, and all are known to be diabetic. So identifying macular telangiectasia compared to diabetic retinopathy is really essential. And this can be highlighted or picked up if you see any patient with foveal microaneurysms only. You need to think or consider the diagnosis of macular telangiectasia. Another thing about locating the leaking microaneurysm, with careful analysis, like in this case, the patient has large area of macular edema, but interestingly, the leaking microaneurysms is slightly away from the fovea, which something you may consider laser for these cases. And oh, sorry, I think this. If you look carefully at the 3D OCT, you can see the leaking microaneurysm is actually located in this area, which is amenable to laser, if you can consider that. Cystoid spaces are often related to microaneurysms. I mean, active leak is usually located adjacent to microaneurysms. And we can see the microaneurysms may be isolated or may be seen adjacent to the cystoid space, and this with leaking around them. Sometimes, in some cases, you may see the microaneurysms as if it's within the cystoid space, and these ones are usually resistant to treatment. Hyperreflective foci, we'll touch it on about by Dr. Gupta. We are actually fortunate that we are the first group to report this hyperreflective foci in OCT. They can present around the cystoid spaces, the microaneurysms wall, and the external limiting membrane. And sometimes, especially when the hyperreflective foci are very extensive, sometimes when the macular edema lead to formation of hardy exudates, which is something to be looked at in some resistant cases. Macular ischemia, we all know that we can detect macular ischemia from fluorescein, but interestingly, we can, if we look carefully at the OCT scan, they can find macular ischemia, like thinning of the retinal nerve fiber layer. We can see loss of the boundary between RNFL and GCL, and we can also see some disruption at the level of ellipsoid zone in OCT scan. Definitely, OCT-A is very useful in highlighting macular ischemia, and we can see the enlarged vas. Yeah, so in conclusion, identifying these microstructural changes can help us to tailor our management and predict outcome. We can detect macular ischemia from OCT or OCT-A even without invasive fluorescein. I strongly recommend, especially junior retina specialists, to look at the integrity of the retina, or to look at the retina as a whole unit. For example, if there is damage to the RBE, there must be some sort of damage to the overlying retinal layer. Also, if there is damage to the anal retina, most likely will be some sort of damage on the underlying photoreceptors. And thank you.
Thank you, Dr. Abdullah, for this nice presentation. It's very scientific. You look deep inside the retina. You analyzed every structure in there.
Oh, thank you.
And it needs a lot of discussion, but we are, we are late, 5 minutes late. But let me ask you one more question, because you showed us many nice, things inside the retina. But would you combine fluorescein angiography with this OCT to know where is the microaneurysm, if it's a macro or a micro? Where is the other lesions you're speaking about, like inflammatory exudate? And he showed us one of the very interesting pictures. He didn't do any comment about it, where the cystoid space is full with hyper-reflective material. Cystoid space like this with a hyper-reflective material, it means chronicity, because it's a very turbid fluid inside a large cyst, which is a chronic and bad visual prognosis. So again, you went deep inside. let me ask you, would you combine fluorescein with this to get more and more information about the retina?
Oh, yeah, thank you very much, Dr. Magdi. Yeah. Yes, I do fluorescein in selective cases. Particularly now we have like the wide field fluorescein angiography. But I would say I rarely do it nowadays mainly for macular pathology. I mainly do it like to check for extent of peripheral ischemia, peripheral neovascularization. But for macular pathology, as a baseline check, I do OCT and OCTA as a baseline, particularly those where I found some sort of macular edema and I plan treatment. And the main point of this presentation, when the patient comes to you with a significant macular edema at a baseline and you are planning treatment, looking at these microstructural changes, you will get an idea whether this patient will have a good response, like if he has mild changes, or whether this patient have some signs of chronicity, like chronic cystoid spaces, chronic leaking microaneurysms, or multiple area of hyperreflective foci. So this gives you a chronicity, and then you can tailor the treatment based on that. So I think the main point is looking at this baseline, especially as you know, with anti-VEGF treatment with diabetic, some patients tend to be very heavy users over time. And some studies saying start with 3 injections, some protocols say start with 5. Some people tend to give more with patient. And once you have this idea, you can plan the treatment accordingly. Also, Dr. Avicii highlighted very important point, whether, let's say, this patient has macular edema with some sort of proliferation, how to plan the treatment. And this also can give you some insight on planning, whether you do treat the macular edema, like I often do very similar, treat the macular edema, a couple of injections, and then start the BRB, and then enroll the patient in like a treat and extend protocol.
Thank you so much, Dr. Abdullah, for your insight, for this nice presentation. And I said it's going to take a very long discussion, but I see Dr. Al-Amri, he didn't speak a word, but I can see his face now. He's going to kill us at the end of this lecture. And others are our panelists. Thank you so much for all the presentations. Thank you, Ramzi. Thank you, Dr. Fak, for co-moderation. Thank you, Abdullah, Dr. Gupta, and Dr. Raja. Thank you so much. And leave the stage to Dr. Al-Amri and hide your faces. Run quickly, leave the space. Otherwise, we are not going to survive this. Thank you so much. Thank you, Dr. Muhammad.
It was an honor to see you at least.
Thank you, Dr. Majdi. Thank you very much. Thanks for all.
Thank you, everybody. Thank you.